Good afternoon, and it's a great honor to address this conference. It's also very scary, although I'm from South Africa, because I only know 3 people. There are 3 people that I've met before here, which is of course great because it's a fantastic opportunity to talk to a new audience about interpersonal violence, which, as Kate mentioned, includes child maltreatment, youth violence, intimate partner violence, elder abuse, sexual violence, which is something we haven't talked a lot about in this meeting, but is, I think, very much correlated in many ways with the collective forms of violence we have focused on. Before getting into that, I'm going to start with an overview of WHO's, the World Health Organization that is, work on violence prevention more generally. In 2015, there were an estimated 1.4 million deaths due to all forms of violence, which is roughly the same number of deaths as due to HIV/AIDS. Of these, 56% were suicides, and WHO's Mental Health Department has since 2014 been ramping up a program to prevent suicide. Also in 2015, it's estimated that war and terrorism accounted for 11% of all violence-related battle deaths, not deaths indirectly due to these things, battle deaths, deaths directly due to violence within the theater of war. And WHO's work to address this includes providing emergency medical services and primary health care in conflict and post-conflict settings, coordinating action to address disease outbreaks in such contexts, monitoring attacks on health providers, and estimating battle deaths. Turning to interpersonal violence, homicide accounted in 2015 for 33% of all violence-related deaths. But for each homicide, there are thousands of non-fatal cases, which have a range of acute and lifelong health consequences, including injuries, non-communicable diseases such as cancers, cardiovascular disease, and diabetes, communicable diseases such as HIV, maternal and mental and child health problems, and mental health problems. These are often ignored by government, who see only the acute and immediate impact of violence in the shape of people who make it to hospital emergency departments, or people who are murdered, or the people who perpetrate such violence. But given this huge range of health consequences, interpersonal violence has been clearly established as a significant health problem in itself, and a major risk factor for many of the top priority public health conditions. Think about all those non-communicable diseases. Interpersonal violence is highly predictable and preventable in terms of person, place, time, and method. Its prevention is squarely within the remit of national governments, and it's a concern shared by all countries. Accordingly, WHO has, since the mid-1990s, been mandated by member states to advocate for science-based efforts to prevent and respond to it. A very different situation in relation to collective violence and war pertains, where WHO is not given such a mandate, and there is little chance of finding consensus among 194 member states about how WHO might do that. So what are the determinants of interpersonal violence, and how can we address them? I think both Max and Andy and Kate have already alluded to several of the more important, but I'll just give a snapshot of this using the ecological model first put out by Bronfenbrenner, a developmental psychologist, who points to the importance of understanding risk factors for violence at the individual, close relationship, community, and societal level. Individual level risk factors include alcohol and substance abuse, psychological and personality disorders, and importantly, having been a victim of child abuse, which of course is a form of violence in itself. At the relationship level, risk factors include dysfunctional family relations and parental conflict, and having friends that engage in violence. At a community level, concentrated poverty, ease of access to alcohol and drugs, gangs, and weak institutional policies are important. At the societal level, poverty and policies that maintain or increase economic and social inequalities, weak economic safety nets, poor rule of law, ease of access to firearms, and cultural norms that condone violence are all important. Significantly, the Sustainable Development Goals adopted in 2015 put the prevention of violence squarely on the development map by including 4 direct violence prevention targets that call for ending or significantly reducing various types of violence. And as importantly, there are several goals and targets that, if achieved, would do much to reduce the underlying causes. These include goals on poverty alleviation, health, education, gender and economic inequality, or gender and economic equality, safe and sustainable cities, and peace and justice. So what I'll now do is go through the prevention potential of each of these goals in relation to interpersonal violence. Goal 1 is to reduce poverty, and 3 targets particularly relevant to violence prevention are eradicating extreme poverty, reducing by half the number of people living in poverty, and implementing social protection systems for all. Should these goals be achieved, there's a very large and consistent body of research showing strong positive correlations between poverty and homicide, and several forms of non-fatal violence, which suggests that this would have a potent preventive impact. Goal 3 is the health goal, and relevant targets include promoting mental health, preventing and treating alcohol and drug abuse, and achieving universal health coverage. Preventing alcohol abuse can substantially reduce homicide and assaultive injuries, as shown here with an example from the Brazilian city of Diadema. As a result of banning alcohol sales after 11 p.m., coupled with public and retailer education about the intervention, local authorities averted an estimated 316 murders and 1,000 assaults on women over 3 years. A second example concerns reducing injury or violence-related deaths through the provision of effective emergency medical services. Given the same severity of injury across 3 sites, the likelihood of dying was just over 60% in Ghana with no such services, around 50% in Monterrey, Mexico with basic services, and around 35% in Seattle with advanced emergency medical services. The SDG Goal 4 concerns education, and targets relevant to violence prevention include ensuring that all children have access to high-quality early childhood development services, and providing education facilities that are gender-sensitive and provide non-violent learning opportunities for all. This is an example from Jamaica, which shows that programs to enhance early childhood development by ensuring that infants are properly nourished and receive appropriate psychosocial stimulation can substantially improve overall development outcomes, which in turn have been shown to reduce the risk of involvement in violence in later life. Schools, quite clearly, are settings where children can be supported in their development of pro-social, non-violent coping and conflict resolution strategies. And systematic reviews of life skills training programs delivered in schools show that they can substantially reduce aggressive and disruptive behaviors, by 25% when given to all students, and by 1/3 when applied selectively to particularly high-risk students. Goal 5 is about gender equality and the empowerment of women and girls. And targets relevant here include ending discrimination against women and girls and eliminating harmful practices. Systematic reviews of what predicts intimate partner violence at the population level suggest that achieving these targets would go far in reducing domestic violence against women. For instance, the predictors include discriminatory practices around education and employment, norms justifying male control over female behavior, and discrimination in family law. By way of interventions, the intervention with microfinance for AIDS and gender equity, or IMAGE, combines microfinance with education on HIV, gender norms, and domestic violence and sexuality. A trial in an impoverished rural South African province found that it reduced intimate partner violence by 50% among women in villages that received the intervention compared to those in villages that did not. SDG Goal 10 is about reducing inequality within and among countries, and targets relevant for prevention here include accelerating income growth among the poorest strata of society, which according to Max we seem to have failed at miserably, thinking of that golf cart, promoting economic inclusion, and enacting fiscal policies that will advance equality. Because we're in the UK, I thought I'd show this. Here there's a six-fold difference in rates of hospital admission for assault across census areas ranked by an index of economic and other forms of deprivation. The rates range from around 6 per 100,000 for the least deprived areas to 36 per 100,000 for the most deprived. This is for the UK, but it's a pattern that repeats itself for homicide and for every other form of interpersonal violence, pretty much wherever these have been systematically measured using epidemiological methods. So efforts to reduce income inequality through tax redistribution should therefore help to reduce violence. And it's therefore reassuring to see from this chart and to hear from Max just how much inequality can be reduced. On your left, and I suspect this is historic data prior to those changes that Max talked about, are shown, let me just show that, are shown 6 Latin American countries that at this point, when the chart was made, did not redistribute taxes and have levels of inequality hovering between 50 and 60. On the right, you see in the blue squares what the economic inequality would be in this group of Western European countries if they didn't redistribute taxes, shown by the squares, versus the much lower inequality rates actually achieved through tax redistribution, as shown by the grey diamonds. Goal 11 aims to make cities inclusive, safe, and sustainable. And important targets for violence prevention here include ensuring access to safe and affordable housing and enhancing sustainable and inclusive urban planning. In Medellin, Colombia, one of the countries in Central America with extremely high rates of homicide, but which in the last decade have started to reduce quite rapidly, and in particular in certain urban areas, the violence prevention potential of efforts to achieve these targets was illustrated by an urban upgrading and public mobility scheme. The aim of this was to increase connections between impoverished slum areas and wealthier parts of the city, and it was associated with a 66% reduction in homicides in the intervention areas. Much closer to here, the Cardiff approach to hotspot intervention reduced hospital admissions for violence-related injuries by 42% and police-recorded woundings by 32%, and saved £82 for each pound spent on the intervention. The approach involves pooling anonymized data received from hospital emergency departments with that from the police, and using this to identify hotspots for violence, in which one then works to reduce the risk factors in those settings. So it's getting tough on risk factors rather than on perpetrators or blaming victims. The final goal, or SDG goal, I'd like to pick out is number 16, on peaceful, just, and inclusive societies. And among the more important targets addressing risk factors for violence are those on promoting the rule of law, reducing illicit financial and arms flows, and providing legal identity for all. Laws that criminalize violent behavior are in themselves an important means of deterring potential perpetrators if those laws are justly enforced. Of course, they mean nothing if they're not enforced. But just as important are laws that address risk factors for violence, such as firearms. In this example, introduction and enforcement in South Africa of the Firearms Control Act resulted in the saving of over 4,500 lives across a 5-year period in South Africa's 5 biggest cities. Subsequent to the period shown on this chart, however, the government has taken the foot off the enforcement gas, and there's been an increase in the rates of firearm-related homicide, at least in a couple of cities where they've tracked this. More evidence for the effectiveness of such an intervention. To end, I'd like to briefly reflect on how interpersonal violence and collective violence may overlap, how they differ, and what this might imply for prevention. I think this cartoon from South Africa quite well sums up what many of us have said across the course of today. So this slide shows estimated homicide rates for the 6 WHO regions for the years 2000, 2005, 2010, and 2015. Notable is the linearity of the rates, their very gradual change, and the chronic high rates between 10 and 20 per 100,000 in the Americas and Africa. By contrast, this is what estimated conflict deaths for the same regions and years look like. Changes in rates are spiky and episodic, and just 2 regions, Africa and the Eastern Mediterranean, are notably affected. And in just 2 of the 4 years do death rates approach those seen for homicide rates in Africa and the Americas. There are no doubt many shared determinants that increase the risk of both collective and interpersonal violence, such as poverty, inequality, access to weapons, poor rule of law, weak or failed governance, climate change, and so forth. But if we look at each type of violence more closely, there may be more differences than similarities. Taking interpersonal violence first, it's generally considered undesirable by most stakeholders. It's highly predictable. Explanations for it are driven by disciplines such as sociology, criminology, public health, and developmental psychology, which increasingly are working together and coming together using the same methods, using the same analysts in the same conferences. Interventions are often initiated and driven by local and national government authorities. They assume adequate levels of governance to implement policies and enforce laws, and they're increasingly dominated by evidence-based approaches. Collective violence, I think, is at the other end of the spectrum on most of these dimensions. War and terrorism are clearly seen as a means to an end by some protagonists. The predictability appears uncertain, and its explanations are driven by disciplines such as peace studies, political science, international relations, and diplomacy. Interventions are usually transnational and often initiated by external governments. They assume that governance and rule of law either have collapsed or are illegitimate, and the evidence base for interventions is poorly developed. To conclude, of course, it's crucial that both collective and interpersonal violence are understood and addressed through a preventive paradigm. To date, and quite appropriately, the threat to global order posed by war and terror means that collective violence continues to receive the lion's share of preventive attention and economic investments in efforts aimed at controlling and ending it. But hopefully we will sooner than later see a world where both the enemy out there and interpersonal violence, that enemy within, receive a level of preventive investment commensurate with their threat to our personal and social well-being. And I think the combination of a public health approach and the Sustainable Development Goals provides a potentially powerful engine for moving us to this position. And WHO looks forward to continuing its efforts with IPPNW and many other partners to realize this goal. Thanks very much.